We are live in 5, 4, 3, 2, 1.
Good evening, everyone. We welcome you all to Ortho TV Online in association with Orthopedic Research and Education Foundation. To introduce today's speaker and topic, I hand over to the Secretary of the OREF, Dr. Janki Badani.
Good evening, everyone. Welcome to the platform of Orthopedic Research and Education Foundation India. Today we have our chairman as expert, Dr. John Upadhyay sir, and the speaker, Dr. Anand Kishore Pal sir, who is teaching us about the pattern, which is the newer one and following in the DNB clinical examination, OSCE system of the examination, which sir will introduce. So I'll hand over to John sir.
I think we can, we have the pleasure of having Professor Pal with us today. And I think this system of examination can be confusing for a lot of people. So now, especially with the pandemic, the chances of it being used more and more is quite likely. Okay, and especially since we don't know whether a third wave is going to hit us or when it will hit us and how badly it will hit us, we really have to be prepared for dealing with this system of examinations. This is basically what is OSCE, which is Organized Structured Clinical Examination. Okay, so there's a way in which you are given clinical findings and are asked questions based on those clinical findings or even a clinical photograph, etc. And the idea is that everyone in the group gets the same type of questions. And so there is a little more balance in the evaluation as compared to when someone may get a very difficult clinical case and other candidate may get a simple clinical case. That's the so-called advantage, but it's a new system, so it's something that people will have to get used to. So I request Professor A.K. Pal, who's got a fair amount of experience in both setting and dealing with this system of examination, to shed light onto this and give his talk today. So Professor Pal, over to you.
So good evening, everybody. So it's my proud and privilege to disclose a new system of examination, which basically is on the OSCE system. Basically, it is an objective structured question, which is completely different. It's a new system, which is completely different from the other system, that is like the multiple choice questions or essay type questions. So everybody, even the teachers, they have to learn. Even myself, I'm learning and day by day to perform the OSCE, because the OSCE preparation for OSCE is extremely difficult, and that has to be prepared as least ambiguous as possible for the students, and because students within the limited period of time, they have to think what answer, and have to write it down. Assess the thinking ability, their technical skill, as also their preparation for the management of the patient. So everything can be tested in a very subjective manner. So this is extremely important. So without any wasting of time, we can just start with this. Can I share my screen?
Yes, please, sir.
Yes. So it's my proud and privilege to disclose this form of treatment.
We haven't got your
examination system, this OSCE system. So there are some general instruction that has to be there. So first, we have to understand what is that. So there are some questions we put in a PowerPoint presentation. So in that case, there must be some time span. So some questions will be 2 minutes, some questions will be 60 seconds, that is 1 minute, and some questions will be 4 minutes. So basically in DNB system, we have to see how much time is afforded for each question. This is extremely important. Sometimes one questions will take 4 minutes. Some questions will take 2 minutes, some question 1 minute. So so the time span is extremely important. Next is the marks. So we have to note. Suppose there are some 2 questions. So it's preferably the marks will be 6 to 10. So normally there is 6 marks. So if there are some 3 questions, so probably it will be 2 into 2 into 2. So that is 2 each. So you have to think of like that. So, but if there are some in one question, there are 2 subset. So that means there is 1 plus 1. So in this manner, we have to go in this manner. Next, we have to observe the picture or the video and then analyze within the time span. It is most important. And with the answer sheet, we have to just write it down to the point answer. There is not much word is required. To the point answer is required. So I don't know whether it will run or not. Is it visible? Is the video is visible? Is the video is visible?
Yes, sir. It's clear, sir.
Okay. See, the question is there. Identify the gate and the explain. So time is 120 seconds. So marks is 2 plus 4. Again, I am running. Just it. See, so what should be noticed within this 120 seconds? See what is happening. See, you have to see the shoulder and also the leg. What is happening in the leg? You can see there's definitely the left lower limb appears to become shortened as there is only the toe is touching on the ground. And again, I can see the shoulder. See the shoulder. What is happening in the shoulder? See what is happening in the shoulder. It is drooping, but at the same time, the body is also swinging on the side. Body is also swinging on the side, isn't it? So shoulder is drooping, at the same time, body is swinging. So what should be the gait? Can anybody tell?
Yes, sir. We have volunteers today. Dr. Sumit Avinash. Yeah, Sumit.
Short limb gait and Tedden back.
Yes, yes, it is a combination of the two. Now, so we have to write it down. See, one is identify the gait is written, isn't it? So what should be is it a short limb gait or tender bug gait?
The short limb gait.
Yeah.
No, it is a tender bug gait. See, why I am telling it. So see, if it is a significant shortening, so that it leads to tender bug gait. So actually, tender bug gait is the ultimate fate of a short limb gait. Okay, so if there's a both component is mixed with this, so you have to write it down. It is a tender bug gait because of the short limb or the significant shortening. You can write it down. Otherwise, you can write it down is a bipedal unassisted gait with a component of short limb and the tender bug component. So this is if you write it down, if you get the full answer, full marks. Otherwise, if you write it down the short limb gait, so you will get the half mark. If you get the only tender bug gait, only tender bug gait, if you get the full mark. Otherwise, so this is the manner we can. So what is the explanation? Explanation is sound side sags. That is why it is a tender bug gait. As the shoulder droops and the significant, there is only the toe is touching. It is a short limb gait. Okay. Now this is another question. See, it's a 74 years lady presented with painful swelling of the right hand and wrist for last 2 years. There is no constitutional symptoms. Okay. Now the question is here. Is written here. There are 2 questions. Mention one inspectory finding of hand and forearm and identify the anatomical structure which is abnormal with explanation. See, the time is recorded for 60 seconds. The marks is given 2 plus 2 plus 2. So that means one inspectory finding hand and forearm. If there is 2 questions, so 2 for the hand and 2 for the forearm, and that is anatomical structure which is abnormal with explanation is the 2 marks. So what is the inspectory finding? Can anybody volunteer?
Yeah, I think this time. Yeah, Sumit.
Swelling at the distal radius, and also thinner area.
Distal radius or distal forearm?
Distal forearm.
Sorry, distal forearm, sir.
Yes, yes. See, yes, you were right. So there is a swelling of the thumb and also the thinner eminence. This is for the inspectory finding of the hand, and there is a swelling of the forearm, distal forearm. See, and if you see from the side, there is the swelling is almost like a dumbbell shaped swelling, isn't it? So which anatomical structure which becomes continuous from forearm to the thumb, and think of that, and that which anatomical structure is abnormal in this case.
I think Avinash. Our second volunteer is Avinash. Yeah.
So how many volunteers are there? How many volunteers?
Sir, I think Sumit, Avinash, Narayan, and 2 more people have joined.
So keep it 3 now. So once one person will answer this, automatically the same question will go to the second person.
Okay.
Automatically third question go to the. Please, the volunteer be ready to make out the time. Otherwise, time will be wasted. Okay.
Because I think I should clear it that the question will go first to Sumit. Next should be Avinash, then Narayan, and then other volunteers you have joined can participate. Yeah.
So which structure? I'm giving the hint as the time is short. So the one structure is basically this is the flexor pollicis longus, isn't it? And it is it is sheath, synovial sheath. So there must be something happening in the synovial sheath of the flexor pollicis longus. Basically, it is the radial bursa. So this is swelling of the thumb and the thenar eminence, swelling of the flexor aspect of the forearm, and there's a dumbbell-shaped swelling, and there's a radial bursa is affected synovial sheath. Okay, so this is the 2+2 distribution. Now the same patient is mentioned. The finding of the same patient shown in the diagram 1, diagram 1, diagram 2, diagram 3 and 4. Okay. Now what is going to be done? So that is the question is, and see this one half into 4. This is the first one. Next, give the pathological provisional diagnosis with explanation. So this is the pathological diagnosis 2 and explanation is 2. So the whole time is 120 seconds. Now see what is being done. See the fingers are going. It is passively extended, but it is not possible to extend the finger fully. So this is being done. It is over. Time 2 is there something circumscribed swelling. Circumscribed swelling is palpated just above the elbow. See this is the elbow crease. Just above the elbow crease on the medial side, some circumscribed swelling is palpated. What it could be?
Ulnar.
No, see, this is a circumscribed swelling.
Is it nerve or a gland?
Yes, it's a lymph nodes. It is a epitrochlear lymph node. Epitrochlear lymph. And see, and last one is easy. See, this is it is being tested the wrist flexion, wrist palmar flexion and dorsiflexion. And see what is the inference. See, only the terminal palmar flexion and dorsiflexions are restricted. And see the face. The face is not very painful. So that means the movements are restricted, but not significantly painful. So what is the pathological provisional diagnosis? This is a dumbbell-shaped swelling. It is persisting for a long period, almost 2 years. There is a lymph nodes, and there is a terminal restriction of wrist motion, which is not significantly painful. So, what should be the diagnosis? Can anybody tell?
Yeah, I think I'll ask Narayan to answer.
There must be some infective pathology as the lymph node is present.
Infection spreading to the synovial sheath.
Yes, which is a chronic infective disease of the synovial sheath of the long flexor tendon. So what should be the diagnosis?
Chronic tenosynovitis.
Pardon?
Yeah, please. He's telling chronic tenosynovitis.
Yes, chronic infective tenosynovitis is the right answer, but we have to write it down. Probably it is a tubercular. It's a tubercular, which is a common in our country. So it is a chronic tubercular tenosynovitis of the flexor pollicis longus tendon. This is the diagnosis. So why the explanation is a long duration, no constitutional symptom, local painful, dumbbell-shaped swelling. It's a basically it is a compound palmar ganglion. Okay. So the restriction of the excursion of flexor tendon and the lymphadenopathy. Okay. Now this is the very straightforward questions, isn't it? This is give the measurement of 105 millimeter screw. It is from the inside. 105 millimeter screw. It is okay. So this is this portion. It requires the measurement, and it is a 90 second 2 + 2 + 2. It is a 6 marks. Is divided into 2. So this is the dynamic hip screw. And what is the measurement of the threaded portion? The barrel portion. This is which type of barrel it is? The short barrel or long barrel?
Or long barrel.
Long.
Long barrel.
Yeah.
Long barrel.
So I think
it is a long barrel because it is 100 by, yes, you are right. So what? So easily you can write. So is the long barrel plate is fixed, is 38, it is 22. So if you subtract 138 plus 22 from 105, you can easily find it the answer. 22, 38 barrel, and it is a 45. Okay. So this is the way we go. Now another questions. It is a 72 years old female presented with history of inability to walk after a trivial trauma 3 months back. See this type of question is given. We don't waste time to read this. See the answer. See the questions. Describe in brief each step for the measurement of the components of the true limb length discrepancy in this patient. So basically, what is asked is what are the steps of true length measurement? It is done, but see the how much jumbling of question is given here. If you think of, if you give some time to read it and see what is the relevance between these questions and also these clinical scenario, you are wasting your time, isn't it? So don't waste your time. So this is go to directly to the question first, and then try to make a association with. There is no association at all. Actually, the question is asked what is the method of true length measurement. This is the question. And the key is, so take, see, this is, I'm going to very rapidly. So take consent and keep one female attendant, explain the procedure. It is marked 0.5. Adequate exposure of the both ASIS knee and the level of the heel from side and top is inspection. This is 0.5. Only check the level of the pelvis. No, if you write it, only check the level of the pelvis, no more. See, this is the way how it go. Check the level of the ASIS. If not in the same level, then square the pelvis and correct the level. So this is the all is 1.5 mark. Now next is the mark the tip of the greater trochanter. It is a mark is 0.5. Now just draw the Bryant's triangle 0.5. Identify the medial knee joint line. This is 0.5. Identify the tip of the medial malleus. Again, this is 0.5. Now it is very important. Segmental length of the femur, that is ASIS to medial knee joint line, the supratrochanteric by Bryant's triangle, and infratrochanteric by subtracting the base of the Bryant's triangle from the total length of the femur. And the tibial length measured from the medial knee joint line to the tip of the medial. Everything to be right in this manner. So maximum mark is 1.5. Measure from ASIS to medial. If anybody write ASIS to medial malleolus, this is also
I think there is freezed.
You've lost Dr. Pal.
Maybe his internet connection may have problem.
I think he's not aware that he can't be heard.
Yes, sir. I'll just also. Oh. So yes, probably left. I think the
Probably going to connect.
yes, sir. It's true. So I think the important thing which I feel is the time. And one more thing which I noticed is that if there is part of question, like some question having 3 parts, and after each part, sir, please unmute yourself, sir. Yes, sir. Please unmute, sir.
okay.
Yes. So we have lost after 6 points, sir. So in 7th point, I have lost.
Have I completed that slide?
Yeah. So
No, sir. Yeah.
Okay.
8th one. Yeah, yeah.
Basically, so the last point just I have to highlight. So if anybody write the measurement from ASIS to median malleus, he will awarded to only 0.5 mark. But if you write all those things, that is segmental length of the femur, ASIS to medial knee joint line 0.5, supratrochanteric branch angle 0. Infratrochanteric is next 0. And tibial segmental length 0.5. But maximum point you will get is 1.5. So that total length will become 6. So that is the actually the actual principle of the DNB mark distribution. Okay.
Sir,
now
so
this is another.
What is the duration to write that answer, sir?
This is a 4 minute. It is only 4 minutes.
Okay.
Total. See the total duration of any question is 4 minutes. Okay. So within 4 minutes that can be divided. Some questions may be divided into 1A, 1B, 1C. That can be divided into 120 minutes. Then another 60 minutes, like that. 120 seconds, 60 seconds, and 60 seconds, like that. Otherwise, it is a total of 4 minutes. That means 240 seconds. Now, this is another question. This is the 59-year-old male presented with this injury of 6 hours duration with swelling around the hand and wrist. There are 3 questions, and the marks is only there is 2 plus 2 plus 2, 6 marks, and it is only it is a 4 minutes. There's 240 seconds are there. So describe the parameters of displacement seen in the radiograph. Can anybody volunteer?
Who want to volunteer?
Yes.
Yes, sir. Sir,
Yes.
this is a plain radiograph of wrist joint showing distal radius, distal ulna, and carpal bones.
See, that is I'm telling. Just a minute. My dear, please just a minute. See, this is the OSCE. You have to write it down very brief. So what is given? This is describe the parameters of displacement seen in the diagram. So basically, you need not write this. This is the radiograph, APL, lateral, everything. So this is this is a dorsal shift, dorsal tilt. What is happening here? It is a dorsal shift.
There is dorsal displacement, dorsal shift, dorsal tilt. There is lateral shift there, and there is impaction.
Yes, very good.
Okay.
Anything?
You say
Anything else? What is happening here?
sorry. Can I come in?
Yeah,
here?
please. So
How
John
do
sir want to.
How do
Yeah.
you say this is a dorsal shift and not a volar shift?
But yes, radiograph is not inadequate. But if unless you see the thumb, you cannot tell that. Yes, but
In fact,
yes,
it looks more like a volar shift.
you are right. You are right. This is the limitation of the radiograph. But radiograph, if any radiograph is given, you will have any very proper view. You have to see the thumb. If the thumb is there, that means the anterior thumb, and it will be anterior. And if the opposite is the posterior.
The scaphoid is going that way, so it should be a volar shift, if anything.
Yes, you are right, sir. You are right.
This is the dorsal part of the distal radius. So
yes, you are right. You are right. Exactly. So we have to write it down everything. And so there is a dorsal or the volar shift, volar tilt. There is a lateral shift, lateral tilt. There is a ulnar styloid. And most important, see over this. So what is happening in the inferior radioulnar joint? Inferior radioulnar joint is overlapped with each other, isn't it? And so there must be something happening over there. That means the inferior radioulnar involvement is there also. Okay, and see the level is also different. So next question is mention the immediate mode of immobilization. What is the immediate mode of immobilization? Can anybody volunteer? Next one.
Yeah, Narayan, you please go ahead.
Sir,
Immediate
first,
mode of immobilization.
we can apply the slab, sir.
So see, you know that, but you have to write it down like this. Manipulation that is gentle or even without anesthesia. So if it is in the OPD, you cannot do anesthesia. So immediately you have to do the gentle manipulation and slotted cast, because it is unstable, isn't it? Either you can write it down the slab or the slotted cast. Both are right. Okay.
Yes.
But slab is basically it is as it is more unstable. If it is write it down, at least slab should cover only 1/3, but if it cover more than 2/3, so that would be ideal one, because it is so unstable. Now next question is mention the steps of closed reduction. It is very easy. So we'll start. Anybody volunteer?
I think
Steps of closed reduction.
yeah.
So first, we'll give the traction, then we exaggerate the deformity. And sir, with the traction,
Traction in which direction? Traction in which direction?
actually, sir, first,
Traction in which direction? This is the most important. You know this but you have to write it down in a proper manner. If the traction is given a longitudinal
longitudinal
direction or in an upward direction.
Under general anesthesia or brachial anesthesia, traction to be given in the longitudinal direction with the thumb and the index and the middle finger.
This is the catch. See the steps. Hold the hand in. See, you write it down. You know everything, but see, once you have tried to write it down, you have to write it like this. Hold the hand in prone by holding the elbow by assistant and extended thumb and the middle ring little finger by surgeon. This is extremely important. Now, disimpaction should be given by increasing the dorsal angulation. That means you have to give traction little bit upward direction first, then traction horizontally against the counter traction. This is the second part. And thirdly, you have to push the distal fragment distally and palmar flexed and ulnar deviated. This is according to the AO manual. I think Dr. John, please support this. This is according to the.
This is for a Colles fracture type fracture.
Yeah, it's a Colles fracture. Next is a check the dorsal cortex and the relative positions of the radial ulnar styloid and followed by plaster. See, these are the steps of reduction of a Colles fracture, isn't it? So this is, you know everything, but once you write it down, you have to write it down. Firstly, how do it hold the limb, how many assistant or how many surgeon, how many persons is required. Next, in which direction we have to start with the traction, then followed by traction, counter traction. We have to how to check whether the maneuver is correct, and lastly the plaster. So this is the way to write it down. Now this is the same patient. Now this is a word round. Check the plaster and the limb. This is the question. Now first question is in upper extent. Upper extent, whether it is transverse or oblique. Why? Mark is 1+1. Can anybody volunteer? Upper
Oblique,
extent.
Sir.
Pardon?
Oblique, sir.
Oblique, very good. So why?
To hold the olecranon pulses, sir.
You are almost right, but basically the why oblique, there is it should be at least one finger breadth below the elbow piece, elbow flexion piece, and one finger breadth below the tip of the olecranon. So that is why it is oblique. So why one finger breadth below? Because that will allow the elbow flexion.
Flexion,
okay, now yes, elbow flexion. Now next question is lower extent. So lower extent. So in the palmar side, in the lower extent should be how much? Can anybody tell? There are two creases: dorsal palmar crease, proximal palmar crease. So in lower extent should be up to dorsal palmar crease or proximal palmar crease.
Proximal palmar crease.
Why up to proximal palmar crease?
To
allow
the
PCB joint.
Yes, to allow the movement of the metacarpophalangeal joint. Yes. Okay. Now base of the thumb should be kept open or closed. Why?
Open to allow the movement.
Yes. Why?
Sir, for movement.
Yes. We allow the movement of the thumb. Okay. Next, what would be the position of the wrist inside the plaster and why?
Pronation and ulnar deviation.
Position of the wrist. Position of the wrist inside the plaster.
It should be pronated and ulnarly deviated because to lock the distal fragment.
Okay, yes, you are right. How much ulnar deviated?
What is the degree?
Pardon?
15 to 20 degrees, sir.
Never. There is another important point that some must be a little bit flexed. That is palmar flexed. Is 10 degree palmar flexed. That is 5 degree, very negligible ulnar deviation, 5 to 10 degree maximum, not extreme movement, isn't it? So otherwise that will hamper motion. Okay, that is the position of the wrist. Next is if the distal radial metaphyseal fracture involves the DRUG, as it is in this case, which modification of plaster is required to prevent the forearm rotation?
Above elbow plaster.
Yes, it is above elbow plaster, but above elbow plaster has some complication. So there is any other option? Any other option? If you go above elbow plaster, that can lead to the restriction of the elbow motion. Okay. So without a restriction of the elbow motion, we want to restrict only the forearm rotation, not the elbow flexion. So without elbow flexion, is there any way to reduce the forearm rotation? Yes, this is the sugar tongue plaster. It's a single sugar tongue plaster. It is done in this manner. See, as in this case, there is the inferior radioulnar joint, the distal radioulnar joint disruption. As you can see in this case, inferior distal radioulnar joint disruption. So for first 2 to 3 weeks, we can do this sort of single sugar tongue plaster, which limits the forearm rotation significantly, but that will not hamper the elbow flexion. But after 2 to 3 weeks, that has to be converted to below elbow plaster, classical police plaster. So this is the way we can go. Okay.
Sir,
Now,
about the, excuse me, sir,
pardon.
about the
Yes,
last question, what you have asked is the position of wrist in the plaster, and about that one, what was the answer is the flexion and ulnar deviation. So
Yes,
the answer
definitely.
which was given is pronation also, but that
No,
is the
avoided
pronation we
zero.
cannot accept, no sir, because that is the forearm here, the DRUJ and all. Yes.
This 10-degree palmaflex with mild ulnar deviation. Extremes of position is strictly avoided. So this is the answer. This is the answer is given here. Okay. Now this is an clinical test. This is a clear-cut clinical test. This is mentioned 4 prerequisites of this 4 prerequisites of this test. It is a very clear-cut questions. Now think of any volunteer.
I think Sumit, you can go ahead.
Sir, knee,
yes.
femur and tibia, thigh and leg is at the 90 degree and hip is at the 45 degree flexion, and sole of the sole of the foot touches the couch.
Okay.
And then thumb of the examiner on the tibial tuberosity and try to pull it the anterior or posterior. For the anterior, it is anterior tower, and posterior tower.
Knee 90 degree flexed, both feet flat on the couch with both heel at same level. Fixation of the foot by sitting of examiner over the toes or foot of the test side of the patient. And most important is the relaxation of the hamstring. Relaxation of the hamstring. It is given, this awarded is 2.4 into 2.5 is a 10 marks. So if you don't mention the relaxation of the hamstring, you will not award the 2.5 marks. You will lose that. Okay.
Can we add no effusion?
Pardon?
Can we add no effusion? No knee effusion, no knee hemarthrosis, because hemarthrosis will not let this test be positive.
No. So these are the basic prerequisites. The basic prerequisites of the ACL. This is, see, this anterior droit test, isn't it? Anterior droit test. These are the 4 basic prerequisites. Okay. Even a very small amount of effusion doesn't hamper these 4 basic prerequisites. Okay. These 4 prerequisites must be there. Otherwise, it will be very difficult to examine. Now, this is this is a radiograph. Now, identify and briefly mention the procedure with explanation. I'm analyzing it. Identify. Identify means it's a radiograph. Whether it is a traumatic, whether it is a operative procedure, whether it is a post-traumatic radiograph, or it is a post-infective radiograph, we have to identify it. Okay. Now, suppose it is a traumatic, then we have to describe the which sort of trauma leads to this. Okay. Or see, this is the clue is there. There is a procedure. Briefly mention the procedure. If there's a procedure it is given here, that means there must be, it is a post-operative radiograph. It's a post-operative radiograph. So it must be a operative procedure. Okay. Now we have to identify the operative procedure and explain that why it is that operative procedure.
Yes. So Avinash, you can go ahead.
And see, there is another important, and the clue is there, 60 years. There is older age.
Yes.
It is a relatively older operation. It is not done nowadays routinely, but previously, suppose it is a 30 years back, it was almost a very common operation in the proximal hip, in the proximal femur.
McMurray operation, sir.
Exactly, very good. It is a McMurray.
Yeah.
Now you have to mention the procedure. So explain that. Why it is called it's a McMurray? Which sort of parameters we can guide you to see whether it is a McMurray osteotomy? You have to write it down in this manner. This is this. These are the same. In this case, that is why it is not. It is a McMurray. Or what is a McMurray? Most of the features of the McMurray is present here. That is why it is a McMurray procedure.
Any volunteer? I think you only have to answer, sir. Nobody is able to.
See, what is McMurray? McMurray, it is, see, this is the trochanteric region, and this is the proximal femur. This isn't it? This is the proximal femur. It's looking like a armchair, isn't it? And there is a femoral head. Femoral head is there. Isn't it? So if the femoral head was not there, so there is a confusion. So confusion, there may be osteotomy in the proximal femur. There is a stabilizing osteotomy. But as the femoral head is there, you are rightly told it is a McMurray's osteotomy. So McMurray, what is McMurray's osteotomy? Basically, it is a oblique osteotomy. It is a linear oblique osteotomy. It is a medial displacement. See, the axis is medially displaced. So a linear oblique medial displacement. It supports the pelvis. See, the whole pelvis can be supported on this. Okay. Pelvic support. So linear oblique intratrochanteric medial displacement pelvic support. That is why every purpose is serving, but there is some complication occurred over here. So complication is occurred, that is the absorption of the femoral neck. Absorption of femoral neck is completely absorbed. Okay, so that is why it is a McMurray's osteotomy. Okay, it's the linear oblique intertrochanteric medial displacement pelvic support osteotomy. Here head is present with the absorption of the femoral neck with overriding of the trochanter. This is a complication. It's a common complication of McMurray's osteotomy. That is why it is not become almost. It is not popular now. Okay. Now,
so, just one question, sir. Which osteotomy is important for exam point of view around the hip joint, sir? May I ask John, sir?
You are opening a Pandora's box. You see, the osteotomy of the around the hip is a very huge subject. So it depends. It requires. It may be a traumatic scenario. It may be a slip capital femoral femoral capital femoral epiphysis. It may be Perthes. It may be unstable hip. Okay, it may be fracture scenario. There are different osteotomies for the fracture scenario. There are some components for the unstable hip. Or different osteotomies are described for the unstable hip. Different osteotomies are described for the slip capital femoral epiphysis. There are the osteotomies especially for the Perthes hip. Okay, and also some osteotomies are described for the providing stability where most of the femoral head neck is absorbed in infective scenario. So you can give sections. Infective, so traumatic section, infective section, the instability section, like the different DDH, instability section. There is a slip capital femoral epiphysis, and also osteochondrosis, that is the Perthes. Then in 5 sections, depending on the 5 section, we have to do the one, or it may be you can again the osteotomy may be suprapelvic, it may be infrapelvic. Suprapelvic may be like the Salters, it may Salters innominate, that is the Dega. The different types of, and then the infrapelvic, that means the VDRO. I will come. I'll come. VDRO is a one.
In last OSCE, sir, probably on the memory based, what they have written is Salters osteotomy. They have asked, and the upper age limit of Salters osteotomy. What is that one, sir?
6 years. See, upper limit is 6 years. Still, why 6 years? Because up to because the Salters osteotomy, the upper
cartilage has to be open. Okay.
Yes, irradiated cartilage is fused by 6 years. So it must be open. This is the primary criteria for the Salter. The whole of the portion of the osteotomized portion of distal portion, osteotomized portion is rotated to make the roof, to increase the roof or coverage of the femoral head. So it requires that fulcrum is at this striated cartilage that should be open. But by 6 years, striated cartilage is completely always obliterated, so it doesn't becomes effective. Okay. Okay, so osteotomy will come. There are 1 or 2 osteotomy. It is in my questions. Now there is a video. I'm just starting to.
Sir, we lost your screen, sir.
Yes, I'm just I'm opening. I'm opening. Is my video is visible?
Yes, sir.
Is my video is visible?
Yeah.
Yes.
Yes. What is the gate? Can anybody tell which gate it is?
I think Narayan, you go ahead.
Again, I'm running.
Yes.
It will get you will get at least 90 second time to see.
I think Sumit.
See what is happening. What important part of the body? I'm giving the hint.
Antalgic gate as the stance phase is reduced.
Trendelenburg gate, sir.
Yes, Trendelenburg gate. Why not antalgic gate? Please explain. Why it is the Trendelenburg gate?
Horizontal swelling of the body.
Yes, very good. So no, not horizontal. It is a swaying of the body in a coronal plane. Swaying of the body in a coronal plane, isn't it? That means sound side sags. Basically, it is a sound side sags. Okay. Now I'm again stop sharing and again share the screen so that. Is it visible? Is my slide is visible?
Yes.
So the video is already you have shown. This is a 10 years old boy presented with gradually progressive limping for last 2 years without history of fever, significant trauma, pain in other joints. Now, first question is identify the gait. We have already identified. That is the Trendelenburg gait. Okay. Now, this is a 10 years old boy presented with progressive limping. There is a painless limping, isn't it? You mentioned 3 possible causes. So, what are the 3 possible causes? Can anybody tell? This is a 10 years old boy. First diagnosis.
Will volunteer.
Neglected neck of femur.
Yeah, think of the common cause. Common hip causes between 5 to 10 years.
Perthes, one.
Perthes, yes. Perthes disease. One. Second.
Slip capital femoral.
See, this is yes, leg called Perthes disease. Coxa vera secondary to united pathological fracture femoral neck. So why you are telling united? United, why you are telling? If it is not united, that means there should be some antalgic component. But there is no antalgic component. That means the stance phase is not short. Stance phase is not short. If the stance phase is short, that means there is antalgic component. Then in that case, you can tell it is a ununited neck femur fracture. But there is no antalgic component. That may be due to coxa vera. Leg Perthes is also this is a coxa vera. Basically, it's a coxa vera deformity. So it may be due to leg Perthes disease. It may be secondary to united pathological fracture, or it may be due to developmental coxa vera. That's why we have keep the developmental coxa vera last, because developmental coxa vera is usually present a little bit earlier age. That is between the 3 to 5 years age. It is a little bit late age. 5 to 10 years, it is ideal for a leg Perthes disease, or it is a united pathological fracture of the femoral neck. Okay. Now come to the next questions. Which most relevant inspectory finding do you expect in such patient? Most relevant. That means the shortening of the affected lower limb. As I already told, if the shortening of the limb is sufficient enough, that will lead to the Trendelenburg gait, because shortening, if it involves the liver arm of the abductor, that will become a ultimate Trendelenburg gait. Same thing happening here. So Perthes disease, the catch is Perthes disease may present with a painless short limb gait, or it may be due to Trendelenburg gait. Okay. Now, next question is, which most relevant palpatory finding do you expect in such patient? Now you can tell, you have to think of a Perthes disease. It is a Perthes disease. So what should be the relevant palpatory finding?
Yeah. Who will answer? Sumit?
Superimmunization of GT.
Pardon? Is higher level of the ASIS, the adduction deformity, and GT at a higher level. See, there are 2 points. You know this, but we have to write it down very quickly. Okay. Now, which movement is commonly expected to be restricted in such patients? So ASI is at a higher level. So which deformity it is?
Adduction deformity.
Adduction.
Yes, yes. Which movement will be restricted?
Abduction.
Adduction.
Yes, abduction will be nil. And along with that, another movement will become restricted. Which one is?
Internal rotation of the hip.
Yes, very good, very good. So you see, this is the answer. Is abduction and the internal rotation movement will be restricted. So in this manner, we have to go. Now, there's another case. It is 8 years old boy presented with limping for 1 year with pain over right groin during the walking and sitting cross-legged for 6 months. This is 8 years old boy presented with limping for 1 year with pain over the right groin during the walking and sitting cross-legged for 6 months, provisionally diagnosed as a Perthes disease. Now the questions: which inspectory finding is clearly visible in figure 1? And which part of the limb should be inspected to detect that finding? Can anybody tell? Pardon?
Shortening of the limb.
Very good.
Shortening of the limb.
Yes, shortening of which limb?
Right.
Right limb. So write it down like this. So if it is shortening of the limb, your answer will be incomplete. You may get 0 marks. Find it. So you have to write it down. Shortening of right lower limb. Okay. Now next question is, which part of the limb should be inspected to detect such finding? Yes, you are right, shortening. But which part? Is it the hip part? Is it the knee, or is the ankle, or anything else?
Ankle.
Which part of the ankle? See, if you write it down, you will get 0.
Medial malleolar or malleolar region.
Pardon?
Malleolar region.
But by inspection, how do you know? See, this is the photograph. How do you know which one is a malleoli?
Sir, the level of heel.
Yes, very good. Very good. This is the answer. See, you know this everything, but you have to write it down the proper word. Okay. Now, next question. Mention the steps of quantification of apparently visible deformity. That means what? They are asking what is the measurement of apparent length measurement? Yes, apparent length measurement. Okay, for the shortage of time, I'm going to just basics is the constant exposure position. Position is supine position. Identification of the suprasternal notch of or xiphisternum. We have to come to the medial joint line of the knee. Medial malleus have to mark it. Tape measurement from the suprasternal notch of the xiphisternum to medial malleoli. First on the normal, then the affected down level. So this is the lab answer. Okay. Now another question is, which inspectory finding is shown by yellow line in figure 2? Now that can be answered.
Right, ASI is at the higher level.
Very good, very good. ASI is at a higher level than the right, painful side. See, this is a simple answer. Okay, now next question is, after palpation, which clinical method is relevant to confirm the abnormality visible in type 2, in figure 2?
Digital brand triangle.
Yes, see, check the abduction. There should not be free abduction. ASI is at a higher level means what? It is a adduction deformity. So there must not be any abduction. Okay. So it doesn't require the GT may be higher level or lower level. So what is direct related with this? We have to write it down. Okay. Next question. Mention 2 method of quantification of the true abnormality of the figure 2. So that means how to measure the true length. What are the method of measurement of true length? Just mention the 2 method. Mention.
Sir, we'll square the pelvis.
Yes, very good. See, this is the answer. So this is squaring of the pelvis. What should we write it down? Like, see this. Method 1, method 2. Method 2 is the drawing the Coteries angle. Okay. Method 1 is the squaring of the every by adduction of the affected hip followed by segmental length measurement. Every word is important.
Method. Can we just write method and Coteries method as method 1 and 2?
Yes, you can write it down. Yes, they are asking for 2 methods. Classical method is the squaring of the pelvis and by the squaring of the pelvis and segmental length measurement. And the another one is the Coteries angle, drawing the Coteries angle. So these are the 2 methods. Okay. Now these are the another questions. 11 years old boy presented with limping and unable to cross leg, provisionally diagnosed as the Perthes disease. Okay. Now identify the clinical test is being done here. Figure 1 and figure 2. Which test is being done here? Can anyone you tell? What is on this? This is the abduction, isn't it? The same thing is happening. This is a flexion in abduction. Isn't it? Abduction is tested in the hip flex, hip extended and hip flex. This is the test. Now, what is the implication of this test or sign? Can anybody tell?
Yes. Avinash?
It tells the region of involvement of the head.
Very good, very good. So it is a you have to identify the mechanical defect of the anterolateral aspect of the femoral head. Okay, this is the answer. Now, why it suggests the diagnosis of the Perthes disease? Is it in favor of Perthes disease or not? It is in favor. So why it suggests the diagnosis of Perthes disease? So this is the answer. This is a Perthes disease due to avascularity of the proximal femoral epiphysis, where the anterolateral part of the femoral head becomes abnormal in shape, which goes inside the confines of the acetobulamic flexion, changing the range of abduction of the internal rotation, which is the basis of sectorial sign. Now mention that any other similar test of same implication to confirm the diagnosis of the Perthes disease. Same implication. It is easy now. You can now answer this. This is the flexion in abduction in flexion of the hip. Same thing is same manner. To know the sectorial sign is
internal rotation of the hip in extension and internal rotation of hip in flexion of the hip.
That is the answer. Change of the internal rotation of the flexed hip in comparison to extended hip. Okay. Just for the students, just I have to show the stages, because there are some questions related with the radiograph. So this is basically the Elizabethtown classification, and this is popularized by our Indian author, is Benjamin Joseph. Actually, this is the stage 1. Stage 1 is the stage 1 and stage 2. There are basically 4 stages of Perthes. Stage 1 is basically it is the avascularity. Stage 2 is basically it is the fragmentation. Stage 3 is it is the remodeling, and 4th is the healing stage. Stage 1 is the avascularity. So what is the radiological sign of avascularity? It is the sclerosis. It appears to become dense. Okay. So the stage 1 is basically avascularity, avascular necrosis, avascularity, and hallmark of the avascularity is the sclerosis. So, and it can be subdivided into 1A and 1B. 1A is the sclerosis, where the height of the head is absolutely normal. Height of the physis is absolutely normal on the opposite side. Is normally what happens, this disease is unilateral. So now it is easy to compare with the other side. If it is a bilateral Perthes, first diagnosis should be multiple epiphyseal dysplasia. This bilateral Perthes is not a common disease. It is a relatively rare disease. First, it is a bilateral Perthes, so we have to always first consider it can be a case of multiple epiphyseal dysplasia. So it is easy to compare with the other side. So it is a 1A, that means the sclerosis is there, but if the height is maintained as in the other side, that is the 1A. If the height is reduced, it is that means it is a 1B. Okay, but they see there is no featuring. Now stage 2, basically it is a revascularization. This revascularization occurs, so that is why. So there are some fissuring occurs. So if it is a 1 fissure, it may be 2 fissure, like that. So it may be either 2 fragment or the 3 fragment or more fragment. Okay, so this is actually fragmentation. So in 2A, this single fissure. So this is sclerosis, that may be flat, and then fissure. Okay, and if it is a multiple fissure, it is a type 2B. Now remember this. This is very important. Up to this 1A, 1B, 2A, and 2B. So if we get the cases, so it can be regenerated. That is, it can be revascularized, and that can be completely cured. But if the patient has come with these more advanced stages, that is in the healing phase or remodeling phase, that in this sort of phase, so it is very difficult to revascularize, very difficult to, that is again there is to get the same sort of normal hip. Normalization is extremely difficult. So it is very important to identify the Perthes disease at which they present. Okay. So stage 3 is basically see, there is a fragmentation is already there, but what happening, there is some calcification is going on the lateral side. So this is it is on the healing is already started. So again, I'm see there is no calcification on the lateral side, it is only fragmented. Okay. So that if there is no calcification, so that means it is not healing is not become started. But stage 3 is the healing started. There's a remodeling, healing and remodeling started. So there is some calcification on the lateral side. But see, this the calcified area, the character of the calcified area is not same on the other parts of the physis, isn't it? So that means it is completely made up of the woven bone. So still up to the stage 3A, we can do the containment. What is containment? Containment is basically that is repositioning the femoral head inside the depth of the acetabulum, so that the whole of the femoral head can be remodeled well. Okay. But see, if this patient has come in this stage, that is already matured bone developed. The matured bone is almost developed on the lateral side. So it is very difficult to remodel. So even if the patient will get in the 3B, so it is extremely difficult, even with the containment. So it is very difficult to get the remodeling. So that is the most important knowledge is, so containment can be done before the patient reach up to this stage, that is 3B. So containment can be done up to the stage of 3A. This is extremely important. And the prognosis is better if we do the containment up to the stage B. But the stage 3, we can do the containment, but the prognosis is relatively bad because the remodeling is already started. Okay. Is it clear? And the fourth is the complete, that is the healed phase, that is whole, if you get the whole of the revascularization. So this is the, now this is the, see, this is how to read the radiograph. So this is Perthes disease, you can see there. Now which stage it is? See on this stage, see the height of the femoral height of the epiphysis is reduced, it is sclerosed, it is reduced, but there is no fissure, there is no fragmentation. Okay, that is why it is Elizabethtown classification is 1B. There is no fissuring, no fragmentation. Cateral depends on the how much femoral head is involved. 25%, 50%, 75%, or whole head involvement. So for the cateral classification, you require AP and lateral view. So if you see the AP and both the AP and lateral view, see the whole of the head is involved. So it is a cateral stage 4. Okay. And the hearing what is telling? There is a lateral pillar. This is the lateral pillar. If the lateral pillar is more than 50%, it is collapsed. That is a very bad prognostic indicator. If it is 50% lateral pillar is maintained, that is a good prognostic indicator. So here it is, see this lateral pillar, you can see the lateral part of the physis. If we see the height of the physis, it is less than 50%. So it is a heading 2. So it is a cateral 4, Elizabethtown, it is 1, and the heading 2. So this is a staging. Okay. Now this is their exercise. Now this is the pardon. Yes.
Thank you, sir. I think we have.
He hasn't finished. Let him finish this.
Okay.
Finish this.
I want the expert comment of Dr. John Mukhopadhyay, because this is my little endeavor to produce this sort of cases.
I think it's excellent.
Okay.
It gives people a good idea of what to expect. And I think there's any number of questions you can have, I guess. So that's the most important part, is to keep practicing.
So this is the question actually, yes. And I will thank to Dr. John Mukhopadhyay, because he has taken a good endeavor to initiate this. This is the eye opener, and I'm really thankful to Dr. John Mukhopadhyay, because unless we help the students, they cannot prepare them in for the examination.
No, I think this is very important, because this is an area where there's still a lot of lack of understanding, and it's important that they understand what is expected in the OSCE, so that they don't. And it's interesting. You can score a lot of marks in it, at the same time lose a lot of marks in it. So it's an area where you can score very high, but if you don't do them right, you'll fail, and that's the big problem. So you need to understand the questions, be very careful about, as I said, read the area that the examiner wants you to concentrate on in terms of time. So don't spend time on, just because you see an X-ray doesn't mean the examiner wants the description of the X-ray. He may be asking for a specific thing. So you need to look at that and then discuss that, okay?
Exactly.
Yes, sir.
Thank you. So thank you, Dr. Janmukhopadhyay. And if you again, if you want, we can again discuss in the later.
I'm sure we can have more questions sometime. Yeah.
Yes, sir.
So I think it's important to have a bank of questions.
Yes, sir.
I have a lot of questions. I can share my experience with this.
Yeah. If someone wants to access your PowerPoint, I think these are recorded, aren't they?
Yes, sir.
So
Yes, sir. It is
over
available
what
on YouTube and Ortho TV. Even on the same link, if you click, you can have access of the video, sir. Even the previous video, what sir have taken or under the OREF India, you can write the name of OREF India also. Then also you have. Yeah, and for the other things, what he's asking for rest of the slides, so we will plan in. I think the practical exam date is not yet announced, or it. Yeah, then
So
before
someone
that.
wants to know the rest of the slides. So I don't know, maybe you can try and get it for people. We'll see.
As per sir, if you ask, if I can provide by email also, you can circulate.
Absolutely.
Yes, sure.
And, we can also add more. We've also got some questions, so we can add them and make a kind of collection of them, which would be useful for people.
Yeah, whatever. In our institute, the weekly OSCE exam, what we are planning to have a book for that one also, so that will be circulated soon, I think.
Okay, great.
Yeah. Thank you so much, sir. It was really great. And before practical exam, I think we'll plan few more classes.
Rest of the question I can send to Janki so that you can circulate. Okay.
Yes, sure, sir. Yes.
Okay, great. Thank you very much, Professor Pal. That was definitely very useful. And I'm sorry we are running out of time, so we need to try and stick to the time every day because there's so many things going on these days.
Yeah, definitely.
Okay. So, so until next week, bye everybody. Thank you very much. Okay.
Thank you so much.
Okay, bye.